Is it recording? Okay, hello everyone. My name is Sarishka. I am an internal medicine trainee in Yorkshire at the moment, and I've done my foundation training in the West Midlands. So today we're just going to go over the acute management stations, because I know that lots of people ask questions about the acute management stations and they are a bit tricky. Okay, so we're just going to go through the slides. I will speak a bit about each slide, and then I'll give everyone plenty of opportunities to ask questions. Feel free to jump in as well, and feel free to put anything in the chat. Okay, so what are the recognition and management of acute illness stations about? Well, as the name suggests, it's about managing the acutely unwell patient. They will definitely appear on the exam. Okay, these are guaranteed stations. You may get up to 2 stations of this type in the exam. So you might get up to 2 acutely unwell stations in the exam. There are 3 ways in which these acute management stations can appear. The first type is the history, examination, and management type. The second one is the history, investigation, and discussion type. And the third one is the easiest one, in my opinion. It's your A to E assessment. Okay, so how will you know which type the examiners want? This will be very, very clearly defined in the scenario. So for this example, does anyone want to read out this example and try and figure out what type of acute management station the examiners want?
Hello.
Hi.
Oh, hi. My name is Priyan. I can read the scenario and I can attempt.
Sure.
Okay. Example 1. Clark Davidson is a 32-year-old male who was admitted with a kidney stone. The staff nurse has become concerned as he seems less responsive than usual and has called you to assess the patient. Okay. Because he has a kidney stone, so the main factors that I draw my attention to in this case is the fact that he's 32 years of age, he has a kidney stone, and he's been less responsive than usual. So immediately I think about the way that I'm approaching this is that I think about the emergency differentials that are leading to loss of responsiveness or fall in GCS or loss of responsiveness. So it could be acute kidney injury, it could be dehydration, it could be blood loss, and acute urinary, so acute obstruction, and then I would do the ABCD assessment, trying to rule in and rule out the key factors that would support or not support my diagnosis, and sepsis as well.
Yeah, so that was brilliant. That was well done. I mean, you got it. Yeah. So basically, this is a young male. You already know what he's coming with, so you know the story. The nurse is concerned and he's less responsive. And the key word here is has called you to assess the patient. So you're going to do an ATV assessment. Okay, so that's how you know what the scenario wants you to do and what the examiners want you to do for each particular scenario. Is that clear, or is that confusing to people?
That's clear. That's clear.
Right. Very clear.
Thank
Yeah.
you.
So you read the scenario very carefully, and the scenario will tell you exactly what they want you to do in that type of acute management station. Yeah, and remember there's three types: history, exam management, history, interpreting and investigation, and doing a discussion, and your ATV assessment. So the second example, anyone want to have a go?
Sure, I'll give it a shot if nobody else wants to. Okay, so example 2. Mark Clapman is a 19-year-old gentleman that was admitted after a collapse at his football game. Please assess the patient and discuss management with him. So this would be option number 2. So we have to assess the patient, do investigation, and discuss the management with the examiner most likely. That's what I would think.
Yeah. So this is very, very clear. Yeah, he's a young male. He was admitted with the collapse, but you don't know what's causing the collapse. So you will need to have a chat with him, ask him a few questions. Yeah, maybe look at some investigations and discuss management with the patient, yeah, or the examiner, and answer any of the examiner's questions. Again, very straightforward. All the information you need is in the scenario. Example 3, so I'll just do this one really quickly. Dorothy Cooper is a 54-year-old lady who's admitted with vomiting. Take a history and discuss management with the examiner. So again, the scenario is very, very clear. It's telling you exactly what to do. You take a short history from the patient and you discuss the management with the examiner.
Sorry, I'm a little bit confused. The number 2, was it history examination management or history and investigation and management?
It's history examination management.
So it's option 1. Okay.
Yeah.
Okay. And the example number 3, it would be obviously history management, but is it investigation or examination?
So it would be an investigation.
Investigation, history, and
okay,
investigation.
but that's not really what I'm focusing on here. What I'm focusing on is that the scenario will make it very clear what they want you to do. I'm trying to stress to everyone to read everything very, very thoroughly.
Okay, thank you.
So for the history, exam, and management type of acute scenarios, these are stations that are very, very pressed for time. So everyone feels a little pressed for time in these stations. What I like to do is follow the 3-4-2 rule. I'm not sure if anyone's heard about it before. It's basically when you allocate minutes for each aspect of the scenario. So 3 minutes for your history, 4 minutes for your examination, and 2 minutes for your management and discussion. 2 minutes is a bit much for management and discussion. I don't envision you taking more than 45, 50 seconds for that, but it's always nice to have a little breathing room at the end of the station. Yeah. You don't have to follow this rule. It's just I've given you something very easy to break it up, and I've given you kind of a reference for when you're practicing. In these types of stations, your history should be very, very concise. You do your introduction, but shouldn't take more than a couple of seconds. You focus on the presenting complaint and the history of the presenting complaint. You do a very, very quick past medical history and your medications history. What type of medical problems do you have? I have diabetes and hypertension. What are you taking for them? Do you have any allergies? That's done, okay? You need to be very, very quick and just very focused and directed on why the patient is here in the first place. It's very easy in this part of the scenario to go down long, winding routes with the history. But just remember at the back of your mind, you're only focused on why the patient is here right now. It has to be a very, very quick, you can do a very quick social, occupational, family, travel type history. The patient is coming with vomiting and diarrhea. Travel history is quite important. Occupational history, what type of work do you do? Things like that. ICE is done very quickly as well. You can do it very quickly. The examiners tend to like ICE a lot. Those of you who've done PLAB 2 might already know this. I tend to phrase ICE in these with these 3 questions. What do you think is the issue today? What is your biggest concern coming in today? And what do you think we can do for you? How do you think we can help you? It's a very nice way of quickly asking ICE. Any problems with this part? No?
Hello. My name is Priyan again. Hi. I had a question about this. In my medical school, I was not taught to take the eyes in acute situations because because they told me that it was not relevant and the patient wouldn't have an idea of, they didn't have the time, or they probably didn't have the ability to give us a concern and idea. So I'm not really sure whether we should. I'm not sure whether I should incorporate that in my examination.
Okay, so if the patient is unconscious and making grunting noises, then obviously there's no point in asking an ICE. If they are in a lot of pain, you can ask it, because those patients are often very scared as well, and they want to know, what are we going to do and how are we going to help them? Yeah, if the patient is able to give a history and would just, you know, maybe they're short of breath and just gasping for breath, and
yes.
Again, they would also be quite scared and want to know what's happening. I don't think it's a problem to just do a very quick ICE. Yeah,
Okay.
it shows the examiner that you're thinking about the scenario holistically and that you're focusing on the patient as an individual and as a person. And that will never, ever be wrong in the examiner's mind. Okay, but if the patient is unconscious, please don't ask ICE, do your AT assessment.
Of course, yes, of course, yeah.
Okay.
Sorry. Hello, sorry, yeah. I have a question. For the ICE, do you have to ask the 3 questions like simultaneously, or can you spread them out during the whole history taken? You
can ask it at any time. Yeah. So what I've given you is just a template. What I've given you, all it will do is it will improve your flow, but you can ask these questions in whatever order you want. You don't have to do things as I've laid them out for you.
All right, thank you.
And what about examination? Do we do just focused examination? For example, patient complaints of Joneses, do we just focus on liver, or we have to do the whole abdominal examination?
I'm coming up to that. Yeah. So examination again should be focused. Examine only the relevant system. If it's an abdominal problem, examine the abdomen. You can look at the peripheries, look at the hands, look at the mouth, look at the eyes, but focus on the abdomen and focus on eliciting what is wrong. Yeah. If the patient is short of breath, again, look at the hands, look inside the mouth, but focus on examination of the chest and the respiratory system. Take your time in auscultating to all the aspects. Look for tracheal deviation, do your chest expansion, tap on the chest, do all of those things. So examine the relevant system, but it needs to be very quick and very focused. Okay, you don't have 7 minutes to take a long, luxurious examination. I'll stand at the end of the bed. I'll have a look for any oxygen or inhalers or vomit bowls. I'll go in a bit closer. Can I please have a look at your hands? Don't do all of that in the station. Do it quickly. Okay, I'd like to have a look at your hands. Can you please open your mouth for me? Okay, I'm just going to have a listen to your chest at the front, at the back, going that way. Is that clear?
Yeah, thank you.
Or whatever system you are examining, it must be a thorough examination of that system.
Are they going to be real patients in the acute management stations or mannequins? I'm a little bit confused. Or is it going to be a person who's going to talk to us and then management?
So I did my exam in 2018. These were patient actors. It would not be very ethical if they give you a real acutely unwell patient. Yeah, that's not very nice for the patient. Last year, I believe there were mannequins for these acute stations.
Mannequins.
So I was just saying to Danielle about the mannequin station for last year. It was you walk into a room, it was a big room, so it was socially distanced. The examiner was just like in a little corner, and you walked in, or you obviously had the scenario on the door, so you already kind of know it's going to be an acute station, an ABCD station, so psych yourself up for it. And you walk in, you see the patient lying there, so it's like a full mannequin, so head, arms, legs, the body, the full shit. And when you walk in, you say hello, you introduce yourself to the examiner, and the examiner will probably be acting as the nurse or like the healthcare assistant or whoever on the side, and he'll say, so this is Mrs. blah blah blah, and she's just been noted unresponsive. And he hands you like a piece of paper with what's happened to the patient. So in my station, it was very clearly a morphine overdose. I can't remember what was written on the instructions exactly, but the patient has had like multiple doses of morphine. It was very, very obvious. So what do you usually see in a morphine overdose patient? They would be like drowsy, unresponsive, and like the pupils would be constricted. So think of all those things when you're doing your A, B, C, D, E. So when you go A, and I sort of went in closer and say, like, I'm just going to check that my patient's airway is patent. So I sort of bent over and looked into its mouth. It's like a fake plastic mouth, but the examiner would say airway is patent. And then you move on to B, and you say, I'm going to count the respiratory rate. And then the examiner said respiratory rate something was very low, morphine overdose. Yeah, can't remember what number. And then you just move on, and then you would say, right, so because the respiratory rate is low, I'm going to put oxygen, and then you just keep doing that. So you would still put your stethoscope on, listen to their chest, and use a pen torch and try and look into their eyes and so on. So do the full thing, but obviously you're not going to get the findings on the mannequin, so the examiner will tell you the findings. Does that make sense?
Yeah, that makes sense now, because I can understand how we're going to get the findings on mannequin. Okay, yeah.
Yeah, so it can be like meningitis where there are rashes. So something that they like to do is just to use a marker pen and just like draw dots on the legs. So do all of those things. So open the blanket, look at the legs, and look behind the ears for rashes. And if you see something, you say like, I note that there are some rashes on the back of the ears, you know, things like that. So you'd still do those things. And if you think there should be findings, or you think there's something that should be found, the examiner will usually tell you.
They will tell us, okay, the findings, okay. And if that applies to mannequins, what about the actress? Because Sarishka mentioned she had actor. Are they going to give the findings? Because obviously the probably simulator won't have any findings either. Are they going to give the findings?
So the patient actor is exactly like the mannequin. They're just there, but all they do is they're able to give you the history in the types of stations where you are meant to take history. So for my exam, it was the scenario that I gave earlier. It was a young man who came in with shortness of breath. He collapsed after a football game. For someone who was short of breath, the actor didn't appear very short of breath to me. He was lying back, very relaxed and comfortable looking, with his hands behind his head. So all I did is ask him a few questions, and the examiner gave me all the investigations and the findings. So they gave me a set of observations, and I think there was a chest X-ray as well. I can't quite recall, but it turned out to be a pneumothorax.
Okay, yeah, thank you.
Okay, so for your management but of these stations, the management is usually discussed with the patient, because your entire encounter and everything you do since walking into that cubicle, walking into that room, is patient focus. The examiner might ask you a few questions afterwards, but they won't be very detailed questions, and just answer the questions. This part is typically very straightforward. I think we were discussing a bit earlier. They don't, they don't require you to go into very detailed types of management, as long as you do the basic things like saying, okay, so for example, if it's a bowel obstruction, you're going to insert an NG tube, keep the patient ill by mouth, and discuss with surgeons and discuss with your senior. That is absolutely fine. You don't need to go into in-depth management for any of these stations.
Fast bleep your med reg.
Don't fast bleep med reg. Right, for your history, investigation, and discussion type of station, the history is, as explained, it is always a very concise history. Yeah, any investigation can be provided for you to interpret. This is usually an X-ray of some kind, a chest X-ray, an abdominal X-ray, but it can be blood results as well. So any blood result under the sun. It can also be arterial or venous gases. It can also be an ECG or anything else that is applicable to that scenario. CT scans aren't usually asked. It's a bit above F1 level. If they do ask, because CT scans have been used more and more frequently now in clinical practice, they do ask, it will either be a very massive, very obvious hemorrhage or massive infarct, again, very obvious. So the hemorrhages are hyperdense, they appear light. The acute hemorrhages appear light. On CT scans, infarcts are hypodense and appear dark. Remember, if your scenario is a stroke, before doing anything, put them into the donut with a non-contrast CT. Okay?
So can I just ask, when you have to interpret bloods, will they give us sort of the normal values on the side, or would we have to just be able to pick up what's abnormal? Would they give us the range of normal values on the side?
I think I was given the range of normal values for my arterial gases.
They would.
Janice, do you want to help out? Yeah, they do. Okay.
They did it.
Because,
I think they did it in the ABCD assessment as well. They gave the sort of regular normal values for respiratory rates. And I think that was it in the ABCD, but in the ABG station they did they gave the normal values, because no one's going to remember normal values for fucking lactate.
I can't, I didn't get any other station with interpretation of lab values other than arterial gases, but I do imagine that they will give you reference ranges. They would expect you to know the reference ranges for the whole panel of bloods.
That's great, thank you. Thanks.
So for your history investigation and discussion type of station, how it's usually structured is you do your history taking. Okay, so first of all, you go into the room, you introduce yourself, you do your concise history taking. You have to mention, we will investigate you for, or we will do a chest X-ray, or I would like to send you for a chest X-ray, in order for the examiner to hand you that relevant investigation to interpret. If you don't mention that relevant investigation, the examiner will not give you anything. Okay? Once you are done with the interpretation, and what I always like to do is I like to verbalize every single thing I do in those stations, because the examiners are not mind readers. They are more likely to score you appropriately if they know and it is very obvious what you're doing. Okay, so I verbalize every single thing that you do. If you're looking at blood results, you say, okay, the pH is high, the lactate is high, the bicarb is low, things like that. So you go back to your patient and you explain your results and your further management. After that, the examiner might ask you a few questions, or they may not. Okay, it really depends. If they do ask you questions, answer the questions. If they don't ask you anything, that probably means you did really good in the station. Take that as it is and move on. Any questions about the management and the discussion?
I think there's a question. What if one isn't sure of the interpretation?
The interpretations are usually very, very obvious. Again, this is a very simple exam, but if you're not sure, you say, I'm not sure, but I have these list of differentials. Okay, the first thing that I'm thinking of is ketoacidosis. The second thing I'm thinking of is this. The third thing I'm thinking of is this. And because this is an unwell patient and I'm slightly concerned about him, I will involve my senior.
And when we give the diagnosis to the patient, shall we mention that's what I suspect, but I will discuss and confirm the diagnosis with my senior, Because I think I read somewhere people saying as a FY1, you have to show that you're a safe doctor. So you always have to say, I will confirm the diagnosis with my senior. So this is my kind of, that's what I suspect. But I will confirm the diagnosis with my senior.
Yeah, so you go back to your, so you go to your patient and you say, thank you for talking to me. Based on what you've told me and based on the results of the investigations that we've done, I think you have a small bowel obstruction. If they ask, oh, doctor, what's that? It means that your bowel is not moving as it should. And we're going to do certain things to try and keep you stable. So that will involve things like putting a tube down your nose into your stomach to try and relieve some of the pressure on your bowel. It's not advised that you eat or drink, so I would recommend that you don't have anything to eat or drink. We're going to give you IV fluid so that you don't get dehydrated, and I'm going to go and have a chat with my senior about this. That's perfectly acceptable.
Good, thank you.
Okay. Right.
Sorry, Charles, could you quickly just repeat that last bit part there? It was a little choppy. I wasn't able to get that last bit part. Just before the one where you said you'd reach out to your seniors and go back to the patient.
Oh, right. I was just giving an example of an appropriate way to go back to your patient, explain the results and explain what you're going to do. So you go back to your patient and you say, thank you for talking to me. Based on what you've told me and based on the results of the investigations that we've done, I think you have so-and-so disease. For that, we're going to do things like give you IV fluids, give you some medications. We recommend that you don't eat or drink for a period of time. And I will go back to my senior and discuss this with them.
Perfect. Thank you so much, Charles.
Yeah, it's just I've just given an example of the way in which you would explain to a patient and the way in which you would incorporate discussing with the senior into your management plan. Because while it's good to say that I'm going to discuss it with my senior, you also have to demonstrate that you're actually doing something yourself. Do you get what I'm saying? You don't want to be the type of doctor or candidate who says, I have no idea what's going on. I'm going to ask my senior. You have to actually assess the patient, get some differentials, get some type of simple management, and then say, because you're unwell, I'm going to discuss it with my senior, and we will both get back to you.
Excellent. Thank you. Definitely get that back.
Okay. Right. So the last type of station is your AT assessment type of station. These are the easiest types of station because there's only one way in which to do them. The patient is often acutely unwell with a decreased GCS or level of consciousness. You do the AT assessment stepwise in order. You must vocalize everything that you do. You must also do everything, as Janice has brilliantly explained it. Okay, if you miss a crucial step in the station, this might mean a fail. So for example, you could going along the steps, going to C. Yeah, you can be pressing on the fingertips to checking the capillary flow, speaking about starting IV fluid, so on and so forth. And the examiner might say, the patient stopped talking to you. You might not think much about it, and you might continue with the C. But meanwhile, the patient has lost their airway. Okay. So that might mean a fail if you miss that crucial step. Okay, so go in order, but always be aware of the previous steps. What they love to do in every simulation station or simulation course that I've ever been to, they love making patients lose their airway. So you'll be going, through your steps. You'll be doing B, you'll be doing C, you'll be assessing the patients and getting your bloods down, blood cultures, putting catheters, checking for rashes, and all of a sudden the patients lose their airway. So you have to go back to A again and start from A, B, C, D, E. Okay, if the patient doesn't have a patent airway, you stay with the airway and you do not move to your other steps. You stay with the airway and make sure the airway is sorted out properly before you move on to the other steps. Okay, at the end, you don't have to come up with a definitive diagnosis. You state your most likely diagnosis. Okay, say what you would like to do, and always say that you're going to call your senior, because these are acutely unwell patients.
Charles, I've got a quick question. If you're not able to, like if you have a few potential differentials that are like, very close by, and you don't feel comfortable isolating one potential, like, differential, is there a safe way to bring in the seniors by letting the examiner know that I'm not comfortable at the moment to isolate one differential at the moment? Is it possible I can say, I'm thinking the investigation results are leading me to believe this, but I'd like to speak to my seniors before I speak to the patient, let them know what I'm thinking? Is that a possibility, or do we have to actually just go with what we think?
For the AT assessment type of station?
Oh no, for any of the, like this could apply to any station. Basically, when you're doing the investigation, you have like results and you're leaning towards a potential diagnosis. If you're not too sure, and if you think a few different differentials could easily, be close calls, can we come up with an answer that could be safe, that could also satisfy the examiner's, parameters, what they're looking at, and a safety cover by bringing the seniors in? How could you give an example of that?
Yeah, so absolutely. You say that, so for example, I'll go back to the bowel obstruction lady. So patients coming with abdominal pain and vomiting. We say it's most likely that it's a small bowel obstruction, but I'd like to include in my differentials bowel perforation, diverticulitis, and large bowel obstruction as well. That's your most likely diagnosis that you've said, your small bowel obstruction, but you've also given a list of very reasonable surgical differentials as well.
Perfect. Thank you so much, Charles. Got it. Thanks.
And I've got a question about the airway. So if the airway compromised or obstructed, we have to stay with airway before we move on. But there's not much we can do, isn't it? We can't do the nasopharyngeal or pharyngeal.
You can.
The airway. Oh, they will give it to us.
Yes.
Oh, they will give us over.
Yes,
okay.
you can do Goodell airways, you can do nasopharyngeal airways, you must do your airway maneuvers. And I don't think they've ever asked anyone to insert eye gels or intubate, but definitely simple airway devices will be there and you must do them.
Oh, they will be there for us to use. Okay. And the simulator will let us know kind of when they lose airway. Will stop talking. How do we normally pick it up?
They might say something like the airways patent, you can move on.
Okay, that's right. Thank you.
Because obviously, while it's important for you to do your AT assessment, they also want to see you do the entire thing, and they want to see you go through each step, so they won't keep you stuck on one aspect. Do you get what I'm saying?
Yeah. Yeah, makes sense. Thank you.
I had a question. So is it the oropharyngeal airways that will be available for us to stabilize the airway?
There should be a whole lot of equipment there, so with various different sizes. So your Goodell, your oropharyngeal and your nasopharyngeal airways will be there. There'll be oxygen masks and just a whole lot of equipment. So you'll need to select what you want, and then obviously you need to do the measurement and insert the correct size.
Okay, thank you.
Okay, so I've put together a list of very common scenarios that tend to come up for the acute management stations. Some of them are high yield, which I've put in here: sepsis of any origin, urosepsis, chest sepsis. It's very, very high yield. You must know sepsis, and you must know the sepsis 6. Appendicitis is also very high yield as the part of your surgical stations. ACS is another high yield station. You must know your chest history. You must be basically perfect with your chest history. Yeah. Subarachnoid hemorrhage, your strokes, your TRAs are less high yield. Your PEs and any type of respiratory disorder is less high yield. Opioid overdose came up before. Anaphylaxis, upper GI bleeds, seizures, atrial fibrillation. Post-op bleeding, I think, is another quite high yield one. I should have put that in there. DK, pneumothorax has also come up quite. Pneumothorax has come out quite often in the past actually, and bowel obstruction has also come up quite often before. So I will edit this and put a few more high yield things in here. But these are the list of the common acute scenarios that you will get. Now, this is not comprehensive. You can get things outside of this list, but I would focus and go over the management plans for each of this. And why I say that is because your history and your assessment will not change for anything. The only thing that changes is your management for each of these. The management doesn't change too much. So for DKA and post-op bleeding, it's the exact same management. You will start fluids for both. Yeah, it's just tiny management details that will change for each of these scenarios. I think that is the end. So if anyone wants to ask any questions.
So, you know, with DKA, it's a very complex kind of management in terms of like, you know, the insulins, like insulin prescribing and the fluid resuscitation. So, I mean, when we assess a DKA patient, would it just be ATE, or like, I mean, how much of the management would we have to actually discuss?
So your ATE assessment will depend on the level of consciousness of the patient or not. If they are acutely unwell, you always do your ATE assessment. If it is a history and you know, investigation and then your management type station, you will need to interpret something. If they give you some arterial gases and they give you a blood glucose level on that gas and you pick up diabetic ketoacidosis, you have your diagnosis. You don't have to go into detail with the management, okay? This is an F1 exam. They are not expecting you to go into detail management about fixed rate insulin and then variable rate after that. Once the patient is eating and drinking, all you have to do is you say, this is diabetic ketoacidosis. You'll get tick, 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 tick on your marking scheme. And you say, I want to start IV fluids right now. And I need to call my senior right now. That is perfectly acceptable for DKA. For DKA patients, these patients are usually seen in A&E resus by the MedReg anyway.
So we don't need to know the details, kind of, we don't need to give detailed management.
No.
So it's like
no,
just the basic,
no.
like obviously.
Picking up that it's diabetic ketoacidosis and saying that you're going to start IV fluids, you can say as well that I'll start the DKA protocol. That's very nice and a safety net. You don't have to know what the DKA protocol is. You can just say, I'm going to start the DKA protocol, and you're going to say, I'm going to get my senior right now because this is an unwell patient. It's perfectly acceptable. And I promise you, if you say it, you'll get all the ticks on your marking scheme.
And shall we say for all acute management stations, shall we always mention we will inform our management, our seniors, and get our seniors involved?
Yes, absolutely. So as I've said before, for all acute management stations, you need to say, I'll have a chat with my senior, or I will involve my senior, because they're all unwell patients. These are not patients that you're seeing on the wards, or okay, there might be patients seen on the wards, but basically they're not stable patients. They're all unwell. So your senior would want to know about all of these patients anyway.
Okay, thank you.
Anything else?
Hi, I just want to ask, will we get the shockable and non-shockable rhythms and the management of those with adrenaline and that kind of area?
Are you talking about ALS?
Because I can see that you put atrial fibrillation, so I want to know whether you might have patients who have compromised, they compromise their blood pressure, and then they stop their heart, and then we need to follow the non-shockable, shockable rhythm.
No. So that's ALS.
Yeah.
You can get with AFib you can get hemodynamically stable and hemodynamically unstable, and then anticoagulation depends on whether it's less than 48 hours or greater than 48 hours of presentation. I've just put it here because it's a common acute scenario. But no, you'll not get any ALS type thing.
Okay.
Okay. So we don't need to prepare the ALS for them.
No, you'll need to do BLS, but not ALS.
Oh, not ALS. Okay, thank you.
So your ALS will be done in F1.
Okay, Thanks.
I have my ALS in a month, if anyone is interested. With AFib, I was going to say, they probably want you to add something like rate or rhythm control, something like that, in terms of like acute treatment, but nothing to do with strokeable. It's not VFib.
Okay, yeah, thank you. Thanks, Sam.
Sorry, where is a good place to look up management protocols based on the UK? Just go to the Oxford manual, or what do you recommend?
You can use the Oxford Handbook of Clinical Medicine. You can also use the Oxford Handbook of Clinical Specialties. Those are good for your surgical type of management. The Oxford Handbook for the foundation program is very good as well. There's also a website called patient.info. If you go onto the professional tab, that's the tab for doctors and healthcare professionals, and they give you very, very nice management plans in bullet form.
Should we know? Sorry, go ahead.
I think OSCE Stop, they have the special section for the acute management stations. Yeah. Are they sufficient to use? Are they kind of good enough?
That's absolutely fine. So as I've said before, they don't want you to go into detailed management, but just having a basic knowledge of the type of management for the scenarios that you are treating will be very good.
Okay, thanks.
So technically, we don't need to know should we know medication classes and doses, or even not too far?
No, not at all. No.
So how would you suggest is the best way that we practice this? Because obviously, if we don't have access to mannequins, or I just feel like it's a different. I mean, histories we can practice together, examination we can practice with other people, but this sort of station, how do you suggest we practice this or get better at it?
I have an idea which we used last year, and which Shah very, very happily oversaw. We had like a teddy bear or something, just like a doll, sort of laid on the floor. So you get your friend or whoever it is that's practicing with you to come up with the scenario. So they will randomly choose, say, DKA, and obviously you won't know anything about what they've chosen. And what we did was we sort of decided on what kind of scenarios and presentation each patient with each condition will have. So DKA, you have all the things that comes with DKA. So we prepared like bits of paper, and went like, when you ask for airway, what would you give? So does that make sense? So we sort of like coordinated that. And that's the way that you would practice, that we found quite useful in my study group. So it's about reacting fast enough and moving forward. Does that make any sense?
So basically, would one of us have a teddy bear, and then the other ones would have to just comment on what therapy we need to give, and then the person would give the therapy on the teddy bear?
Yeah, so you can like make up things that you think looks like a medical stuff. So you can use a teddy bear, you can use a pillow, whatever is you have on hand, and I think we even set up like a timer and a room, so the person would stand like round the corner, and when you start the timer, they come around the corner, they have an instruction sheet right in front of them, they read it, and so somebody in the room would be acting as both the examiner and the patient coordinator, so they'll be giving out scraps of paper and sort of testing the candidate. Does that make sense?
Okay, yeah, thank you.
Quick question regarding the marking scheme. So are these stations out of 30 or 25?
25.
And so what is the global mark, if you look at it?
It's sort of, okay, Shah, if you want to explain.
So the global mark is just 5 points. It's how you perform globally in the station, how well you flow, how well you talk, in certain stations, if you are certain aspects of the history in order. It's basically how your overall performance is. It's very subjective. It's what the examiner thinks.
I think, Shars, when I read online, it was, yeah, you're perfectly right, exactly that, what you just said. But I think overall it said that the examiner's overall intake of how you performed and how you basically came off to the examiner. So if the examiner thought that your communication and how you basically interacted with the patient was something according to the line of the professional guidelines of GMC, that's exactly what the global mark would reflect.
Yeah.
Right. So that global mark's not included in the pro forma of your 25 points then. It's just there
It
as
is. It is.
So it's 20.
5 out of that 25.
Yeah. So it's 4. So it's 4 sections of 5. Does that make sense? 4 marks per 5 section plus global marks, so 5 points.
So
Oh,
Miles,
okay, I see.
basically, yeah.
Right.
So Miles, basically that rubric that you have with all the check mark that they're doing for all the steps that you're doing about the examination history, all that stuff. At the end, there's a global mark that's only going to be subjective to the examiner himself. That mark is basically going to be what the examiner felt, how you did overall. And that mark doesn't have any subcategories that the examiner has to fill. That's just one section where the examiner is basically going to say how he felt about your reflection on that performance. That's it. There's no single category in there for a global mark where there's going to be like, oh, in the global mark, was the history good? Was the examination good? No, the global mark is just how the examiner reviewed your performance for that station. That's it.
Okay.
Right. Anything else?
Hi, hello. I have a question regarding prescription stations. I want to know that if there are references given for the medications we would have to prescribe, let's say a BNF would be provided or something like in a paper form. Like how much medications do we need to know extensively?
Right, so we will do a separate session on prescribing and the prescription station in this exam. This is only for the acute scenarios.
Okay, perfect. Thank you.
Hello, sorry, I have one question.
Yeah, go ahead.
Yeah, I'd like to know how many scenarios actually have this acute management and all acute scenarios. How many do we have?
So I've spoken about that at the beginning. It's at least 1 or 2, and it's definite. It will definitely come out in the exam. They will definitely test you on acute management.
Thank you very much.
Anything else?
The OSCE cases with Mark Scheme's book is really, really good. I would thoroughly recommend everybody used it, especially as a patient. So if you're playing someone's patient in your practice sessions, you sometimes can just make up things, but having the book and the Mark Scheme is really good because then you can sort of tell your friend what you've missed. So really recommend using that.
I have a question. Sorry.
I have a question not about acute stations, but in general history taking questions. How important it is to complete the stations or to ask family history, social, smoking? Because I think the problem we're currently having in my study group, we don't finish it. We kind of only reach until family here, until past medical history. We don't even sometimes reach till past medical history because taking all the differentials, the history presenting complaint and then differential questions just takes up all the time.
So in the larger scheme of things, if you have an acutely unwell patient in front of you, it's not that important at that moment in time to get a family history or a social history. Yeah, because they're very unwell and you want to know and you want to focus on why have they come in and what's the history of the presenting complaint. So that's the most important thing. But you do need to ask the questions very, very quickly. So for example, in the social history, I'm not sure what you're asking, but the only things you need to know about, do you smoke, do you drink, do you do any illicit drugs? That's it, move on. Okay, you don't need to go about, you don't need to go into sexual history or things like that because it's not relevant. I'm not sure if that helped or made any type of sense.
Yeah, it does. Sorry, I didn't clarify. I meant no normal history taking stations, not the acute stations. I know this session is about acute stations, but I mean in normal
taking stations.
Is it important to complete? Yeah.
In normal history taking stations, it is very important to complete everything and to ask all the questions. So yes, you must ask all the questions.
We have to ask everything past medical family. So if we don't, if we run out of time and we don't ask those questions, it's kind of a loose mark.
You will lose a few points, but I don't think you'll lose a lot of points. Yeah, as long as your flow is good, you've asked an appropriate amount of relevant questions, and you've come up with a list of reasonable differentials, you won't lose a lot of points.
Oh, okay, so it won't be fail. It won't be automatic fail if we don't complete the question in the station. No.
I think that's highly dependent in terms of where you stop. If you spend like 5 minutes asking all the differentials in the world, then that's not ideal, isn't it? So I think the best way to tackle sort of not making the time is to practice with a timer. So always set your timer for 8 minutes. I think history taking is 8 minutes, and you have 2 minutes or 1 minute where the examiner might ask you some questions, I believe. I can't remember, I think it's 8 minutes. So set a timer every single time you practice, and then you sort of get an idea how long the 8 minute stretches, even without looking at a clock. So anytime you feel like you're asking, oh, I'm actually asking too many questions, time to move on. And it's absolutely fine if you have absolutely no idea what's going on in the history of presenting complaint part of the consultation, because you will find out later on. So keep moving and practice with the timer.
Yeah, it's very easy to get stuck in histories and to go down like long winding routes. You always have to think about what are you focusing on and get back to what you're focusing on, because the point of taking history is to come up with a differential, isn't it? To get a diagnosis.
And normally I normally tend to ask lots of differentials questions. So I normally have about 9 or 10 differential diagnoses in mind for the condition, and I try to ask questions for all of them. So that's kind of an issue. So would you recommend to have less DDs? Would you say like it's a good idea just to have to cut down DDs like to 2 or 3 and try to do 2 or 3? One?
The history taking patients aren't very challenging. It's in your face, it's staring in your face what the diagnosis is. It's not, it's not something out of house or anything like that. But I would say try and find questions that you can cross out 3 DDs by asking 1 question. Does that make sense? So that saves you.
So only select 2 or 3, because normally I know what the diagnosis with after a few questions. Even history of presenting complaint is enough to know the diagnosis. As I said, they're very straightforward. But then I try to show the examiner that I'm trying to exclude all the DDs. So I ask lots of DD questions. So you would recommend to only choose like 2 or 3 DDs and try to exclude 2 or 3 DDs rather than go through the whole list of them.
Yeah, of course, that's not the point of the station. The point isn't to show off your knowledge. The point is to show how you communicate with the patient and how you are concerned about their sort of situation. If they're worried about something else, they might not even be worried about their diagnosis. They could be worried about how they're going to look after their kids, or who's going to look after their cat if they go into hospital, things like that. So it's not about showing off your knowledge at this point.
Yeah.
Oh, okay, that's useful to know. Thank you.
So I would say if you already know the diagnosis within the first few questions that you ask, there's no point in going through a whole bunch of differential diagnosis questions. Okay, do 1 or 2, yeah, and then move on.
Okay, thank you.
Right. I think I'm going to stop the recording here, but anyone have any more questions?